This episode is with Charlie Gourley and Simon Herrington, professors at the University of Edinburgh. Both working on the molecular and genomic characterisation of ovarian cancer, Charlie is director of the Nicola Murray Centre for Ovarian Cancer and clinical director of the Cancer Research UK Edinburgh Centre. Meanwhile, Simon was president of the International Society of Gynecological Pathologists and is editor-in-chief of the Journal of Pathology Clinical Research, all alongside his work as a consultant gynecological pathologist. This episode is slightly different to the usual setup in that all the questions were surrounding endometriosis and cancer, and so this was really just scratching the surface of what their research entails, so I really do encourage you to delve deeper into their incredible research into ovarian cancer. I hope you enjoy this episode as much as I did, and thank you so much for listening. Okay, so I was reading, and you said that around 50% of clear cell carcinoma cases were associated with endometriosis. But I was also reading elsewhere, and someone said that maybe it's the iron that's produced from the endometriotic cysts that's increasing the ROS or oxidative stress, and that's what might be causing the mutagenesis. And progression into clear cell carcinoma, but I was interested in your thoughts on that.
So, well, I'll let Simon come in a minute because he's probably better placed to answer. But the one thing I would say from the genomic perspective is that we know that some of the genetic precursors of clear cell ovarian cancer are already, or the genetic events are already manifest in endometriosis. And so for that reason, I think if this iron thing was involved, it would be as an additional factor rather than as being the alternative explanation. What do you think, Sam?
I think it's unlikely to be a driver.
Yeah.
I would say it might be a kind of passenger event or a secondary event, because, as Charlie says, endometriosis contains a lot of the molecular abnormalities that you see in the tumours, both clear cell and endometrioid. So yeah, I've heard this idea that iron somehow, because when we look at them down the microscope, they're full of hemorrhage, endometriotic cysts, very often. Although interestingly, I mean, if you look at tumours arising in endometriosis, you don't see a lot of iron and pigment around the place. So if that were correct, you'd expect there to be association between hemorrhage and tumour formation, which anecdotally, and certainly from my experience, I wouldn't have.
You don't see. Okay.
That, no. Doesn't mean it doesn't have a role to play, but I don't think it's necessarily a driver.
No. Yeah. Okay. No, that's good, because there was a few papers that were saying no, a few papers saying yes. So I was interested. But yeah. So you were saying that it's the ARID1A gene that's mostly mutated, and I was reading that instructs chromatin remodeling. But what genes would that dysregulate? What's the downstream effect of that?
So that's a bunch of genes called the Swiss-Nif genes.
Okay.
Now I think I've got a slide about this. Let me just see. I mean, Simon, do you want to see it? I've got a slide I can.
Yeah, the whole Swiss-Nif story is interesting in tumour pathology in general. ARID1A is just one gene in that complex, and it's chromatin remodeling complex.
Mm-hmm.
I mean, one of the S's is sucrose, I think, but it's a very complicated expansion of Swiss-Nif. But there's a lot of interest in Swiss-Nif deficiency, loss of function in tumours in general. ARID1A mutation is more common in clear cell carcinoma than in endometrioid carcinoma, both of which, of course, arise in endometriosis. So there's something peculiar about clear cell differentiation that appears to be associated with ARID1A mutations. Although, if you look at patient outcome, ARID1A mutation seems to be a good thing.
Yeah, I was looking at that, and I was a bit confused of how that can be, how the 2 and 2 go.
It doesn't necessarily mean that ARID1A is good. It means that perhaps something else that we don't know about is bad. Do you see what I mean?
Right.
And obviously, sometimes loss of function mutations, because they lead to loss of function, may actually reduce the tumorigenicity. I mean,
Okay.
P53, for example, is the opposite. So that you see gain of function mutations there. It acquires a function that is tumorigenic or tumor promoting. And why ARID1A mutation is associated with these tumors is, as far as I'm aware, unknown. But there are drugs, aren't there, Charlie, that are targeting this.
So there are strategies because it's felt that, you know, ATR inhibitors, PARP inhibitors may work better in patients who have an ARID1A deficient tumor. You know, that's yet to be definitively shown.
Okay.
I'm trying to find this.
I mean, other genes in that complex include the SMARC genes. Have you come across those? So and the SMARC genes are mutations of those are associated with really aggressive tumors.
Okay.
SMARCA4 is one, SMARCB1. You see them in some of the aggressive pediatric tumors. So there's something odd about the chromatin remodeling complex. Some of the genes are bad, or mutations in those genes are bad, and there are lots of function mutations as well.
Okay.
So there's a lot to be understood about that particular complex.
Mm-hmm.
And we do see ARID1A mutations in endometrioid carcinomas. So the relationship between endometrioid and clear cell carcinomas in the context of endometriosis is pretty unclear, because we sometimes see mixed tumors. So in a single tumor, you will find both clear cell and endometrioid carcinoma. Yeah, there you go. Switch sucrose non-fermentable.
Can you see this? Can you see this?
I can, yeah.
So this is the sort of so basically it affects transcription of
Okay.
a bunch of genes involved in all these different processes: cell migration, interferon signaling, etc., proliferation, etc., etc. And this is the model for how it works. And so there's a balance between differentiation and self-renewal. And if this complex is inactivated, then it promotes proliferation rather than differentiation.
Yeah, so if you look at the SMARC genes, SMARCA4, SMARCB1, for example, they're associated with really dedifferentiated tumors. And something in endometrial cancers, if you lose SWE/SNF function, usually SMARCA4, SMARCB1, then they dedifferentiate. So that fits with that idea. But ARID1A doesn't seem to do that.
Yeah. No, that's right. Because if it did, you'd expect it to be associated with worse prognosis, wouldn't you?
And I suppose the other point about mutations in genes is that sometimes there's functional redundancy.
Mm-hmm.
So mutation in a particular protein can be compensated for by the function of another.
There's certainly, I'm just stop sharing. There's certainly, you know, a considerable grey area in terms of our understanding of all of this. You know, there's no question of that.
Okay. Yeah. No. Thank you. I guess that's also linked to why, because my next question is why do you think that the serous borderline tumours are not associated with the endometriosis? But I guess that's linked to what you were just saying.
It's just they're on a different pathway. So
Okay.
borderline tumours cause low-grade serous ovarian cancer.
Mm-hmm.
And whereas endometriosis causes clear cell and endometrioid ovarian cancer. You know, I'm not aware of significant overlap. I have to say there was one paper that showed a very weak association between endometriosis and low-grade serous ovarian cancer.
Yeah, I mean, sometimes in burnt-out endometriosis, you see lesions that look serous.
Yeah.
Because the ciliated cells become predominant. But the other thing to say, I guess, is that there are borderline tumours associated with endometriosis called seromucinous borderline tumours, very confusingly, but they're a different thing.
A different beast.
And they are related to endometriosis quite tightly. I mean, you almost always find endometriosis.
So, you know, maybe that's the reason why that study misclassification has caused this. So I certainly don't think of those two processes as being on the same track.
And serum mucinous borderline tumours can look very similar to serous borderline tumours.
So that's
It can even be WT1 positive sometimes.
So that's probably
what's going on.
Because that was quite a big study, and it was published in the Lancet Oncology, and but the association with serous borderline was weak, and the association with clear cell and endometrial ovarian cancers was strong. So I suspect that's probably the explanation, misclassification. Yeah.
Okay. Yeah, that makes sense. Yeah. So I've also read that the endometriosis is not just a disease of the reproductive organs, but can be found all across the body. So I was wondering why there's not like more research going on into it, because surely that could have links with many different cancers, not just like ovarian and things like that. Or maybe can it? Is that possible?
It's from going for you, Sam.
I mean, we do see endometriosis-associated tumours outside the female genital organs. So the most commonly they're in the ovary. But rarely you see them in the pelvis. Probably associated with pelvic endometriosis. Sometimes in the anterior abdominal wall, but again, it's probably peritoneal endometriosis, isn't it? You can see endometriosis anywhere. I mean, the classic is pleural endometriosis that causes catamenial pneumothorax.
How does that happen?
Well, so that kind of phenomenon led to the idea that endometriotic tissue was in some way invasive and could get into the bloodstream and spread like a metastasis. But when it gets to the distant organ, it doesn't actually behave like a malignant tumor. It just grows like endometriosis. But because endometrial tissue has the ability to invade in quotes, and certainly during pregnancy, if you think about what happens with placentas and all the rest of it, that whole organ system has that ability. But I've never seen endometriotic carcinoma or clear cell carcinoma outside the peritoneal cavity, I don't think, other than the metastasis.
Yeah. No, absolutely.
An endometriosis-associated tumor in the pleural cavity, I've never seen that.
Yeah.
Or you can get endometriosis in muscle. I mean, the classic examples of people having it in their arm, for example.
Yeah.
And you talk about the lack of research. I mean, that's very true. There is actually a group here that has a specific interest in endometriosis and are kind of world leaders in it.
Yes. Somebody called Hilary Critchley. So she does a lot of research into endometriosis. I mean, not specifically it's linked to cancer, but more just endometriosis research.
And Andrew Horn, they run an endometriosis service, really for Scotland and probably beyond, to be honest.
Yeah.
So they've been involved in this area for a long time. Our view of it is very cancer-centric, isn't it? There is a cancer, is there endometriosis, rather than there's endometriosis, what's the likelihood of development of cancer, which of course is a small proportion.
Yeah.
And you mentioned the 50% figure, this idea that if you've got these cancers, you see endometriosis in 50%. There's a big ascertainment bias involved there because it depends how hard you look.
Yeah.
So in the past, we haven't looked very hard because we're interested in the cancer.
Yeah.
Now we're looking harder and we're finding it more often.
Yeah.
So the link and the association is becoming stronger as we look more carefully.
Right. Okay. Yeah. So it's maybe to do with like the pH difference and why it doesn't cause cancer in different areas of the body, or something along those lines.
It might be simply due to the ability to proliferate in those sites, that the disease is much less active.
Yeah.
I suspect that's what it is. And so, yes, it could eventually cause a cancer, but it would take much more than a lifetime to do so,
Yeah.
Because the tumours tend to be associated with very proliferative endometriosis.
Yeah. Okay. Yeah. Because I've also been reading, and there's not much really on how endometriosis comes about in the first place. I was wondering whether you know more about, but maybe I should contact those people who you said.
Yes.
Well, I mean, the classic theory is the so-called retrograde menstruation theory. So the idea is that during menstruation, the shed endometrium doesn't just go downwards, it also goes upwards and out of the fallopian tubes. And that's why the ovaries are the commonest site. That's why it can get into the pelvic, the pouch of Douglas, into the pelvis. And I think there's some evidence for that. And it probably, and intuitively, it seems the most likely mechanism. It doesn't explain why you can get it in other sites in the body, obviously. So there is something else. And there's no reason why there can't be more than one mechanism. I think most of it is retroactive, to be honest. But I don't have any evidence for that.
So because of all of this, do you think there should be better screening and diagnosis strategies for endometriosis? And how could that be achieved, seeing as though there's such a high association with clear cell carcinoma?
So the association with cancer isn't, I mean, there is an association, but the incidence isn't actually that high. I mean, it's a reasonable question that you ask. But one thing is that the cancers that arise from endometriosis, well, the suggestion from some of the work that's been done, some of the work that you're doing, is that it may have a better prognosis and it may present at an earlier stage, at a stage where you can actually deal with it. Don't get me wrong, there's still people who die from it. But, I'm just remembering that Lancet Oncology paper. I think if people had endometriosis, the risk of clear cell cancer was, just off the top, I need to check, I think it was sort of 5-fold more common or something like that, But given that, so if you're going to screen for something, for a cancer, you need a group of patients who have quite a high incidence of the cancer, and it's kind of debatable whether that's high enough. But even if it was, you need to have a situation where your screening is going to cure them when they wouldn't normally be cured. But if a bunch of them are going to be cured anyway, then I guess the economic rationale for screening is less. Do you see what I mean? I mean, I don't know if anybody's talked about screening these people.
Not specifically in endometriosis, but ovarian cancer screening in general, yes. But I think there's also the harms of screening, and they're not just physical harms, they're psychological and all the rest of it, that if you start screening a population for abnormalities. And I think also what I'm seeing with endometriosis, as a pathologist, I see endometriosis all the time. Low volume endometriosis is really common and it doesn't cause any problems, so it's asymptomatic. If you start diagnosing everybody, or more and more people with endometriosis that isn't actually symptomatic, isn't really going to cause them any harm, then that will create its own problems.
And then screening would then, in other settings, like for example, people with BRCA1 and BRCA2 mutations who definitely have a high chance of a nasty ovarian cancer, screening hasn't even been shown to be effective in them yet. We don't have a good strategy. So there was a big study that looked at doing ultrasounds and taking blood tests to look for a protein called CA125. And when they did that, the patients who had that sort of more rigorous follow-up, it really didn't make any difference to their outcome. So you need a reasonable screening strategy. I mean, I don't think it's a completely unreasonable suggestion, to be honest. What we should really do is we should really look at our patients who've got endometriosis-associated cancers and work out how many of them actually, died of their cancer, I guess.
Yeah, I mean, I would say that sometimes from a pathological point of view, we will see people who've had an operation for endometriosis and they have an incidental cancer. Rather than them presenting as
a cancer. Although all the ones we're reviewing just now, when you go back, you find that some of them have got endometriosis.
Yes, that's right. So it works both ways, but we not infrequently see this unexpected diagnosis. Somebody's had an operation, what is considered to be benign disease, and then they turn out to have a cancer.
Yeah, exactly.
Usually a small one, usually low stage, and usually good outcome. Yeah, exactly. As you said, but nonetheless. So I think, and the UK trial of ovarian cancer screening, ran, well, like a long time ago.
Oh yeah, I mean it was a monster undertaking.
Yes, and it really didn't show any benefit.
No.
I mean, they've scrambled about with the statistics to try and show some
something,
benefits, subgroups. But the reality is, and that's based on ultrasound and CA125, and I know there are some modifications of the RMI, aren't there, like these Nexus scores and all sorts of ways of trying to interpret the radiology in more and more subtle ways to try and improve the predictive power, but it's still, not great.
It doesn't work well,
Yeah, so it quite possibly might do more harm than good for now.
That's the issue.
Exactly.
Yeah. I mean, I know that the breast people wouldn't like this, but I've heard people say, if you were to try and introduce breast screening now,
yes,
it wouldn't happen.
Right. Okay.
Because you're detecting, what is it, 5 or 6 benign lesions for every malignant one.
Yes.
You're putting a whole population through this, and then you've got the whole issue of lead time bias.
Yeah.
So you diagnosed it early, so you think the patient survives longer, but they haven't actually.
Yeah.
So screening is it's a whole can of worms, actually.
Yeah.
The one screening program everybody agrees has worked is cervical screening.
Definitely.
Because that, I mean, you can
No
see
question.
the graph.
That's just awesome. Yeah.
Yeah. That is another thing as well, actually, because obviously because of HPV and the cancers that causes, and how that's caused by a virus. I've read that endometriosis can possibly be caused by a bacteria. So I guess in terms of the screening, that could also come into play there. Like you could be screening for the bacteria if that was, chosen to be,
So I wasn't aware of that. You would have known.
No, I think that the problem with that theory is the cause and effect problem, because endometriotic cysts get infected.
Yeah.
And so just because you identify a bacterium doesn't mean it's caused. I mean, so I worked in HPV many moons ago, and this was a big problem when the HPV world, in the 1970s, everybody thought the cause of cervical cancer was herpes simplex virus.
Right, okay.
And everybody was convinced. And then in the 80s, the whole papillomavirus field took off. And Harold Sohausen said, yes, it's HPV. And everybody went, yeah, right. No, we know it's herpes. This guy's mad,
Yes.
But actually, herpes simplex was acting as a surrogate marker of infection.
I see. Yeah.
Because they're
so infected, yeah.
And it turned out to be HPV, and he got the Nobel Prize.
Wow.
So that the idea of infective agents causing cancer is quite difficult to prove.
Yeah.
You need both epidemiological evidence and you need laboratory experimental evidence to show that the viral genes or the bacterial genes can actually influence the cell in a way that's relevant to cancer development.
Yeah. There haven't been many cancers that have been associated with bacterial infection. But
I was thinking, I was reading this, I was like, I'm not sure.
Yes, that's
the most famous one.
Yeah.
I just thought that was interesting.
Right.
Anyway, I think that's pretty much all my questions, other than like, what would you say would be the next steps from here?
There would be, I think there is scope. Something we've not done, and we probably should have done, is we haven't created a formal link between our team and Andrew Horn's team.
Yeah.
And that would actually make
it would be very,
because they've got an absolutely enormous endometriosis tissue set, and we've got one of the best curated ovarian cancer tissue sets ever.
And we're just expanding, or Rob is expanding the endometrioid.
Exactly.
So
So there's potential. Let's put it that way.
That's
wonderful. Thank you. Well, that's everything.
Okay.
Well, good luck.
Aye. All the best.
Have fun.
Your endeavours. All right.
All right.
Okay.
Thank you for your time. Thank you.
Bye.